Let people into the webinar just to make sure it works for them.
It's running, yeah. Good afternoon, everyone. We're going to get started in about 1 minute. We'll let a few more people come in for lunch. Just a second. Thanks. Need to get back. Okay, let's go ahead and get started. It's It's great to see everyone together. It's great to be back at EASL and actually beginning to see more and more people face to face instead of always through a video screen, and see a number of close colleagues that I've worked with over the years, and really excited to meet a number of new colleagues that are all committed to hepatitis C elimination, which is what we're here to talk about today. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health in the United States, and with my colleague Lindsay Hebert here. It's my pleasure to convene this policy forum to examine our progress toward hepatitis C elimination in Europe. What are some of the issues around health equity for the populations at highest risk for hepatitis C, but maybe the most difficult to reach for a variety of reasons, and what's the recent armed conflict in Ukraine? How has that posed a new population that we need to be concerned about? I'm going to be introducing my co-moderator here in a moment, and you're going to see we have a very rich group of speakers to talk about their experiences in Ukraine, Moldova, Romania, Poland, Lithuania, and Georgia. And then we'll have a great panel discussion to give a broader context of how this means more broadly in Europe and globally. Next slide. Just to, I call it a little mental calisthenics to give us, we get focused on, what special moment we are upon when we think about hepatitis C elimination. Not every disease, is positioned as hepatitis C is to be eliminated. And it really it started in many ways with the discovery of hepatitis C virus in 1989, or when it was first reported by these three gentlemen here that were awarded the Nobel Prize in Medicine and Physiology in 2020 for their collective work that led to that discovery, which made the reliable tests we have now possible and the curative treatments that we have now possible, as well as improving the epidemiology for us to really identify the risk factors for hepatitis C, as well as the natural history of hepatitis C. And I'm very proud that Dr. Harvey Alter is a member of the Coalition Executive Board, and we work very closely with him because he recognizes the special moment that we're in, whereby it's our opportunity to turn this Nobel Prize level research into practice so that people all around the world can benefit from this scientific discovery. Next slide. At the Task Force for Global Health, I started the coalition about 4 years ago with Lindsay and some other colleagues that are here with me. I moved over after 13 years of directing the Division of Viral Hepatitis at the US CDC, where I was responsible for a variety of research, surveillance, and policy development. I got involved globally, working with WHO and with some of the countries you'll be hearing about today, as well as working with a variety of partners in industry to develop public-private partnerships that expand our work. And one of those was AbbVie, and I'm very appreciative of AbbVie being a supporter of the coalition and of this policy forum. But we seek to do our work in three ways. We want to build a community of practice by bringing people together to share their lessons learned and experiences. So that's why we're convening this policy forum. Secondly, strengthen the evidence base for hepatitis C by sharing those lessons learned. You're going to hear some very novel strategies today that I think that can be applied globally. We provide direct technical assistance ourselves and do some operational research. And then thirdly, we know that hepatitis C is an underappreciated, underrecognized disease. People don't really recognize the special moment at hand, and we want to do our part to increase that awareness and bring more partners to the table so that we can build the capacity needed to achieve hepatitis elimination goals. Next slide. And we really focus on helping programs get started and be successful. And when you look at the history of disease elimination programs, which I've gotten to be more familiar with because the task force operates and manages a number of global disease elimination programs, you realize all of them have these essential components. They have good information, they have a national plan, they have policies to go with that plan, they have a community understanding and buy-in of the program, they have political commitment, the government's involved, they are beginning to implement strategies appropriate for their health system, and then they have a financial plan so that all that work can be supported, and then they have data all along the way to help them improve their program and help them understand when their goals have been achieved. Now, the other key element of this is health equity. Really, the ultimate goal of disease elimination is health equity, because how otherwise can you eliminate a disease if you're leaving parts of your communities out of your effort? And so it's really part and parcel of disease elimination is health equity, and that's what we're focused on today. Next slide. Now, we work with partners in countries to help them come together and collectively, civil society, clinicians, national governments, to help them understand what is the status of their planning, policy development, implementing prevention, testing, treatment, and how well is that going, what's their achievements, what's their challenges, and work together to understand feasible next steps. So you can really develop that local coalition that can work together to solve those problems. We've developed about 30 of these profiles. They're available on our website at globalhep.org. Georgia is an example in the room today that has developed a profile. We're working. Ukraine will be releasing one here very shortly, and we look forward to working with all the countries represented today in developing these profiles. Next slide, please. So that's our example of building local coalitions. We also have been working at the regional level, sort of as we are here in Europe, to get this community of practice strengthened and helping countries, programs share those lessons learned, learn from each other, and realize that they're part of a larger effort than that their day-to-day experience may suggest. So in Asia, we had, with the Asian Liver Association meeting, we brought together a policy forum similar to this with a call to action of what was needed in those countries and in Asia more broadly. We helped convene the North American Hepatitis Elimination Summit, which included Canada and Mexico to do a similar sharing of information and calling for improvements. And then just several weeks ago in Africa, we convened about 12 African countries and Africa CDC, WHO, others to have this type of presentations and discussions that we're going to be having here this afternoon. And I think it all shows that there's real leadership in many, many countries, and there's really a number of positive efforts underway, and progress is being made toward elimination. And it's a good, for me, it's a good reminder that we have to be persistent and maintain our passion, even though the challenges can be large. If we stick with it, progress can be made. And I think you'll see some examples of that surely here today. Next slide. We really wanted to focus on Europe for several reasons. Number one, it has the largest number of HCV infected persons by WHO region. It's high in the number of new infections, high in mortality rates. It has a large number of people who inject drugs with high rates of infection. And then we have inequities that you'll be hearing about today for people who inject drugs, the incarcerated, perhaps geographic barriers such as rural populations and socioeconomic status, their insurance coverage, and then migrants, refugees, internally displaced persons that we wanted to focus on, which has always been an issue, but has been brought into more visibility with the recent Ukraine refugee situation that we'll be hearing about. Next slide. And And also, we need to do better collectively. We need the proportion of persons who are HCV infected, who are aware of their infection and being treated, is not yet at the standard that WHO has set to reach the elimination goals. And we have to work to do to reach a key risk population of people who inject drugs in testing and treatment, as well as the prevention services that can prevent transmission among that population. So this just gives you some of the background about why this policy forum is important. So what we'd like to do is go over these various populations in the context of their burden of hepatitis C, look at some of the strategies being employed for prevention, testing, and treatment for those populations within the countries, and then begin to identify some ways forward to overcome the health inequities to eliminate hepatitis C. On our part, we really see this as an opportunity to grow this community of practice, particularly in this particular part of Europe. Develop a call for action that we're going to be going over and agreeing on at the end of our time together. We're going to come together with a policy statement that will capture our presentations and discussion today. And they're really going to use that to communicate it as widely as possible so we can get more and more partners engaged in our work and supporting our work. And I really greatly appreciate all of you attending today and look forward to your presentations. And please, join in the discussion when we ask for questions and comments, because that's when we can really have a really fully very interesting meeting. Next slide, please. So this is just the agenda. We'll be having some presentations from the countries that you see here, and I'll be obviously we'll be presenting their introductions in more detail in a moment. Next slide, please. And then we'll have a discussion with those presenters, as well as others that you'll be introduced to after our break. And please stay for the full program. I think you'll find it very interesting. At this point, I would like to turn it over to my co-chair, Mr. George Kalamitis, who is the general manager of the Hellenic Liver Patient Association, which is a non-governmental organization in Athens, Greece, and he's current president of the Liver Patients International, which is also located in Athens, Greece, perhaps because you're located in Athens, Greece. Maybe that's the wrong thing. But George, please say a few words to welcome everybody.
Thank you very much, Dr. Ward, for the invitation and for this organizing this very interesting meeting. My name is George Kalamitsis. I come from Athens, Greece, and I am the co-chair of ACHIEVE, which is another coalition of umbrella patient organizations from Europe, but also international patient organizations like EATG, European AIDS Treatment Group, World Hepatitis Alliance, European Liver Patient Association, the Correlation Network of Harm Reduction, and IC Global from Barcelona. So there's a few things that I wanted to state with you before we start this meeting, the presentations. I have made a few remarks here. I'm also chair of the Hellenic Liver Patient Association, and I would like to address the crucial topic of achieving equity in our efforts to eliminate viral hepatitis. Despite the progress that has been made, viral hepatitis is far from ending epidemic that is falling short of the 2030 WHO Global Hepatitis Strategy and Global Elimination targets. Impetus is very much needed. While we recognize that the European Union competence in health matters is limited, it is crucial that we acknowledge the role the EU can play in addressing health inequalities among member states. In our fight against viral hepatitis, it is crucial that we pay particular attention to the needs of refugees, migrants, but especially also to other marginalized populations. These individuals often face unique challenges and vulnerabilities, including limited access to healthcare services and social stigmatization. In this fight, the principle of health equity should guide our efforts, ensuring that all individuals, regardless of their socioeconomic status or geographical location, deserve equal access to screening, testing, treatment for viral hepatitis. By supporting this principle, we can make substantial progress towards our shared goal of eliminating viral hepatitis. The United Nations Sustained Development Goals provide a clear framework to drive our collective efforts in improving health and well-being globally. The EU has committed to help member states in achieving the UN SDGs, including health-related goals and help measuring progress. This commitment must ensure that no one is left behind in our fight for viral hepatitis. Thank you very much for the attention, and I look forward for the upcoming discussion.
You, George? Okay, well, let's get started with our presentations from countries. Let's start with Ukraine. It's my pleasure to introduce Dr. Marina Alessandrova and Dr. Anna Prihodko. Dr. Alessandrova is a specialist in the management of viral hepatitis and opioid dependency in the Department of Public Health Center of the Ministry of Health of Ukraine. She has 13 years of experience in molecular diagnostics and virology, and she's responsible for the coordination of the national program in Ukraine. We're very happy to have her. Please.
Thank you. Hello, everyone. I want to express my sincere gratitude on behalf of our entire team for the opportunity to participate in such an event and to discuss the current situation on viral hepatitis in Ukraine. This is extremely important to us, especially during this challenging period for Ukraine. Russian wars against Ukraine has been lasting for more than 10 years now. The war started February 20, 2014, when Russia invaded and annexed Crimea and partly to east regions for Ukraine. Before dawn on February 21st, 22, Russia launched a full-scale invasion across Ukraine from multiple directions using land, sea, and air. By sunset, Russian special forces and airborne soldiers had seized the nuclear site of Chernobyl after a bloody battle and were advancing into the outskirts of the Ukrainian capital, Kyiv. Ukraine is successfully fighting against the enemy. Intense battles are happening in a lot of cities and regions of our country. We, however, know that we are protecting our land, our relatives, and the future of our children. More than 22 million of people were forced to leave their homes and began seeking shelter in safe areas in the country. There are 8 million of refugees from Ukraine across Europe. The Ukrainian healthcare system also faces obstacles. Many healthcare workers were forced to abandon their jobs and evacuate from dangerous areas. A number of healthcare institutions were relocated. Many Ukrainian doctors had to seek jobs abroad. The military aggression of the Russian Federation resulted in a big number of human casualties, migration within and beyond the country's border, and all of these factors are directly reflected on the country's population. From recent events, the shocking crime of the Russian army is bombing of the Kakhovka hydroelectric power plant in the south of Ukraine, resulting in the flooding of vast areas of nearby land, populated villages, and the city of Kherson, which will have huge ecological and social consequences not only for Ukraine but for the entire world in the future. Ukraine faced 5 months of active attacks on the country's energy infrastructure, which created a significant risk of blackout. Despite that, we continue to move forward. So what kind of problems our aggressive neighbor left behind? Occupation of certain regions and territories, difficulties in the logistics of drugs, medicines and other supplies within regions, damage or destroyed healthcare facilities, here and after HCFs, medical workers fleeing to other regions and countries while others facing overwhelming amount of work and cannot physically cope with it. Disease spread as a result of limited access to medicine and discontinuation in the treatment of chronic diseases. A number of HCVs were damaged, of which more than 118 were completely destroyed and cannot be restored. Also worth noting that Ukraine suffered significant economic losses because of the war. Despite the difficulties caused by the war, it is important to note that the Ukrainian government is taking measures to improve its healthcare system. After the full-scale invasion of the territory of Ukraine by Russia, one of the main challenges is to restore the medical infrastructure and ensure access to high-quality medical care. Despite all the challenges over the war, Ukraine is already implementing country's recovery plan. We want medical care to be high quality, accessible, and of course free. There is a great deal of work to be done on the deoccupied territories. Needless to say, the mental health of all people, both civilian and military, was also traumatized. However, with the support of the country's First Lady, programs related to the management of the mental health are developing rapidly in Ukraine these days. And by 2023, more than 100 tasks are placed at track of digitalization. The implementation of the medical information system, monitoring of socially significant diseases is being implemented successfully, and telemedicine is being implemented as well. And now let's dive deep in HCV program itself in Ukraine. In 2019, the Cabinet of Ministers of Ukraine approved the state strategy of HIV infections, AIDS, tuberculosis, and viral hepatitis elimination by 2030. The country strategy corresponds with the WHO's. According to the strategy, 90% of new cases should be prevented. Up to 90% of infected individuals will be aware of their status, and 90% of HIV patients will receive medical care and treatment. To determine the number of patients who should be tested and treated each year, the CDA in 2018 calculated elimination scenarios for the country. Our objectives are presented on the slide, and currently we can see that we are significantly behind the implementation of the goals, and therefore they need to be revised, and the deadline for achieving the goals of elimination needs to be postponed. According to estimated data, 5% of the population in Ukraine is infected with HCV, of which 3.6% have a chronic disease, and 1.5% of population is infected with HBV. Biobehavioral studies are conducted for key groups every 2 years, and the results are used to estimate the prevalence of HCV in this population group. The prevalence among donors is regularly collected, and the PHC has an entire unit dedicated to this matter. However, it's not available publicly since the war. In the country, mass screening for HIV markers among prisoners was also conducted. 30% of the 22,000 individuals tested and have positive results. The number of people who tested for HBV and HCV hepatitis markers is presented on the slide. After 2020, we can clearly see a decrease in the number of people tested for HBV markers because of COVID-19, which followed immediately by the war. We have data regarding HIV testing, but it fails to accurately represent the situation. The slide illustrates the gap between the number of people tested positive for HIV markers and the number of confirmed cases, as well as the expected number of confirmed cases. Thus, we lost a significant number of patients during the diagnostics phase. Currently, the country's HIV monitoring system cannot conclude the exact annual number of HIV-related deaths. On death records, the cause of death is listed such as hepatocellular carcinoma (HCC) or cirrhosis of the liver, but its etiology is not specified. To obtain enough data about death rate from HIV, the PHC with WHO have conducted a cross-sectional study. The results are presented on the screen. 8.5 thousand people die from HIV every year. According to the data obtained on the slide on the right, we can see that the number of deaths from HIV and TB is significantly lower than from HIV, which corresponds to the global trend of decreasing mortality from TB, HIV, and malaria, while mortality from HIV is only increasing. Next slide. Thank you. Among the advantages of the diagnostic in the country, first of all, screening for HIV with a rapid test is included in the list of services provided by family doctors and also included in 11 package of the program of medical guarantees. In 2022, for the first time, rapid tests were procured with state budget funds. Limitation includes the following. There is no separate PMG package for HIV, lack of free confirming diagnostic. Most patients have to pay on their own. Therefore, there are patient losses. The graph shows a decline in testing across the country. Absence of standard laboratory, absence of an electronic system with all diagnostics results. Currently, free vaccination is available only for children in Ukraine. Vaccination is suggested for the other groups of people as well, but at their own cost. In Ukraine, HPV vaccination of infants began after the year 2000. We can see that throughout the year, the numbers of children who get vaccination decreased due to anti-vaccination campaign and the pandemic of COVID-19. In addition, Ukraine's vaccination rate was reduced by the full-scale invasion. Thus, the need for vaccination of the adult population against HIV and HBV of military personnel, medical workers, and representatives of services involved in providing assistance to the country population has become critical. In 2019, the government of Ukraine began funding a harm reduction program in the country. Because of current budget deficit, the Global Fund took over responsibility for funding the program services. Yet, we wait for a return of state fundings. And please pay attention to HCV prevalence among key groups on the right. So when it comes to harm reduction program, we all understand that prevention programs are the same for preventing HIV and hepatitis. But we see that the efforts for HIV are not enough because the prevalence of hepatitis is still increasing. When we are looking at harm reduction programs, we should mention about opioid substitution therapy as one of the most effective preventive programs for HIV and hepatitis. In the context of hepatitis elimination, it is worth mentioning that OST program was implemented in Ukraine in 2004. Since then, the program has achieved significant results and it's considered one of the largest programs in the Eastern Europe and Central Asia regions. The main achievements are mentioned on the screen, among which drugs are procured with state budget funds. We also have progressive policies including standards of treatment, 95% patients receiving RT, etc. What should be noted is that the treatment can be provided by any trained doctor. Also, a number of training courses has been rising. Moreover, ambitious objectives are set for ST implementation, even though we are currently facing Russian aggression. What kind of challenges we have to face when the war began? Just to name a few. Difficulties with the logistics of OST medicine, risk associated with the lack of the OST drug, difficulties with the arrival of patients, medical workers. National drug manufacturers stopped working. Since OST is prohibited in Russia, OST program had to be stopped on occupied territories. Migration of OST patients. Despite the tremendous number of challenges, Ukraine managed to overcome most of it. So what has been done? Orders were implemented allowing to take home medicine for 30 days. Another order allowed to store 3 months' supplies of drugs in healthcare facilities. A new OST drug was received as humanitarian aid called PWID. There have been steps taken to support the mental health of OST physicians and patients. A pilot project on video monitoring of the self-administration of OST drugs was launched, from procurement of drug supplies from the national manufacturers. All the actions resulted in the expansion of the program, which is fantastic. As February 1st, 2023, we had 25,000+ OST patients and had accomplished 110% of its initial goals, which is undoubtedly successful. In Ukraine, the system of infection control or prevention wasn't set up until 2018. In the last 2 years, a number of infection control measures aimed at enhancing infection control and prevention antibiotic resistance were implemented. So what are the necessary steps to achieve the goals? It is digitalization, data management and accumulation of strategic data, accessible testing, optimized patient routes and simplified approaches to diagnostics and treatment, accessible medicines and also developed infrastructure of healthcare facilities. Among the achievements are the following. A large-scale decentralization of viral hepatitis treatment services has been carried out. The image shows the progress of the situation from the start of decentralization before a full-scale invasion and throughout the war. In some regions, the number of institutions may be decreasing, but in frontline areas where active hostilities are occurring, HIV continues to be treated among both the civilian population and the military, despite all of the challenges and difficulties. In addition, the number of healthcare facilities where patients can receive treatment are restored and expanded. In 2021, new modern standards of care for HCV and HBV were approved. The key aspects are used of the most simplified diagnostics and treatment methods, and the right to prescribe and carry out treatment can be given by any doctors, not just an infectionist. Currently, the standards of care are being reviewed and amended in accordance with the latest international guidelines and standards of care. Regarding the treatment of HCV, we are currently observing a significant rise in HCV treatment coverage, which is mainly due to decentralization and the availability of generic medicines of viral hepatitis in Ukraine. The coverage situation for HBV treatment is worse, unfortunately. In Ukraine, generic medication are used for the treatment of HCV with the exception of the 3G regimen. However, the manufacturer has reported that this medicine has been removed from production, leaving Glycopivir as the only available alternative. The declared cost per course for Ukraine is $16,000. This is extremely expensive, thus a major dilemma for the country, as the national budget cannot cover it. Therefore, we will be unable to treat a specific category of patients. To ensure transparency and to make services of the treatment of HIV fully accessible, digital tools have been implemented, such as chatbot. Also, information about drug residues in the regions is posted on the PHC website, and there is a map indicated health centers where rapid tests can be handed out. Among our key achievements, you can see information campaign, new online courses, pilot projects, and etc. Due to the difficulty in providing medical assistance in some areas, the risk of HCV and HBV infection increased. Not always is it possible to provide this assistance using every available infection control approach. A little bit about increased risk of HIV infection. Currently, it is challenging to figure out the scale of the consequences after attack of Kakhovka Dam. However, what we do know is that the problem of HIV and other infectious diseases is serious. Unfortunately, in Ukraine, vaccination against HIV is not included on the list of required immunizations, resulting in a low vaccination rate. Due to migration, the risk of HBV and HCV spread in Europe is increasing. On the basis of our population estimated prevalence for HCV, we can conclude that approximately 400,000 HCV-infected individuals and 120,000 HBV-infected individuals migrated to Europe. I would like to add that the majority of them may be unaware of their condition and therefore may not seek medical assistance. The majority of the tremendous obstacles created by the war are being solved. We have done continuum of decentralization, logistics of drug between regions. The program of viral hepatitis is still financed by the state budget. Expansion of HCV treatment among key groups in narcological clinics. Expansion of OST program during the war. Changes in standards of care for viral hepatitis. To conclude, while there is a number of activities that we have already managed to successfully implement, we still need to work hard. Our top objectives are listed on the screen, and it is ensuring the availability of expensive drugs for the treatment of HCV, screening strategy and free diagnostics, studying the potential of self-testing, telemedicine for the treatment of HIV, adjust elimination scenarios and update data for decision-making, initiatives and activities aimed at elimination for HIV among military. Thank you for your attention. If you will have additional question, I will gladly respond with my colleague Anna Приходько.
One of the limitations you mentioned was the lack of a good data system to collect information about the number of tests. But it seemed like you had some good data regarding the number of persons being tested. So what's your current system? How do you currently collect data regarding the number of persons tested and treated for hepatitis C?
The main data source is for us is just communication with the departments and regional departments of healthcare. So we get the data from them. Now we are currently developing the module that will be implemented to the medical informational system. It is electronic system, and we are forecasting that the managing of the data in electronic way will be more available for us. Now it's just like a handing. Thank you.
Questions? Any other?
Eventually, because as I imagine, it's very hard to know on the records if a person can be retested, for instance, on the data you present. Because I fully agree, it's quite a big number. I mean, it's great work considering the situation you have in the country.
Thank you for your question. It's a good question, and we also are thinking about this problem because we have no electronic system for checking all results of diagnostics, and it's area and that's problems we try to discuss and.
It is a gap right now. Yes, we understand it, but we will try to improve it, and we are working on it right now because we know that it is challenging very much because we are not quite sure that the data is available and be presented. Thank you.
The other area that in thinking of prevention of HCV among people who inject drugs, you did mention the access to clean injection equipment for people who inject drugs, and I'm asking, was there any disruption in the supply of that, or the community groups that probably helped you distribute those clean injection equipment to people who inject drugs? Has there been any changes in that part of harm reduction?
Yes, the main we are working with our partners, non-governmental organization, as well as partners in regions. So I guess they have a very good and very big part in this. So non-governmental organizations in regions, so they also controlling these harm reduction programs, as well as supplies chain and procurements for that. Thank you.
Do you have any evidence that the number of people who inject drugs are increasing or decreasing because of some of the mental health issues and some of the other issues that you raised?
So the number of people is increasing. Sorry, yeah.
Yes, Sanai.
Thank you, Dr. Ward. Senan Hadaragi, CDC. So question about blood products and blood safety. Do you have any data on testing blood products? I assume there's a huge need because of all the fighting that is going on. So any data from that, and also any challenges of testing blood products currently in Ukraine?
Thank you for the question. We are working only on prevention and harm reduction and viral hepatitis. So we had also other departments. It is cross-cutting them. So to be more clear, we need to discuss it and to clarify with our colleagues. And after that, we can tell you.
Yes, and however, is not available publicly since the war. It's we cannot. Share the number of this.
Marcelo from WHO Europe. Sanad, it's with the Ministry of Defense, the blood safety data. So they're not allowed to disclose. We had partners like Médecins Sans Frontières, Paris, trying to work with the group in Odessa, and they found the same obstacle. But the country office, we can definitely connect and get something working.
Thank you very much. You can come back around for a discussion later in the program. Thank you very much. You want to introduce Sylvie? You want to introduce Sylvie?
So let me introduce the next speaker. From Moldova, the National Public Health Agency, Dr. Silvia Stradrilat, correct? She's the head of the Department of HIV Infection, Viral Hepatitis Surveillance at the National Agency for Public Health, Republic of Moldova. And the rest, you think it's a big one? She graduated from State University of Medicine and Pharmacy in Nicolet Testamitantu in 1995 and Management School of Public Health at same university in 2011. She has wide experience in the prevention and surveillance of HIV infection and viral hepatitis. She has participated in the elaboration of several normative, informative, and educational materials in the field of HIV and viral hepatitis. Excuse me? Okay. It's a big CV. Well, we have good speakers. So she has participated in the development of the law of the Republic of Moldova on prophylaxis of HIV/AIDS infection, National Program for Combating of Viral Hepatitis 2011-2025 year, National Program for Prevention and Control of HIV/AIDS and Sexual Transmitted Infections for the years 2006, 10 and until 2025. Standards and guidelines of HIV infection and viral hepatitis. She has provided several workshops and training for services providers in the field of HIV viral hepatitis. I think the rest is the floor is yours.
Thank you very much. First of all, I would like to thank you for invitation and participate at this very important event for us, because elimination of Hep C virus is one of the big problem in our regions. I will try, please put my presentation. Thank you. Republic of Moldova has a high prevalence of chronic hepatitis and of course, and the liver cirrhosis and primary liver cancer. In 2022, above 75,000 people were recorded with chronic hepatitis, and the other 10,000 were recorded with liver cirrhosis. About 64% of hepatitis cases are caused by chronic hepatitis of viral etiology, and officially being recorded above 50,000 cases. Hepatitis C constitutes 31% in the etiological structure of viral hepatitis. In Republic, the registration of reduction of incidence of acute viral hepatitis B, C, and D, but there is increase the incidence of chronic forms of viral hepatitis, and hepatitis C in 2022 form chronics incidence constitutes 32.75 cases per 100 population. Viral hepatitis both chronic and acute form is registered predominantly among adults and with unique cases among children. Viral C hepatitis predominant in the etiology structure of acute forms in 2022 constitute above 68%. But the study that was provided in the country show that in our country we have very high seroprevalence of hepatitis C among key population, key vulnerable population, among drug users, sex workers, and MSM. For example, hepatitis seroprevalence among drug users constituents in 2022 among 50%, among sex workers 8%, and among MSM around 5%. Compared with the general population, where the seroprevalence is 2.28%. In the last time, I would like to mention that the estimation exercise provided in our country in 2022 shows that in the Republic of Moldova there are around 55,000 persons infected with HCV virus, and in 2022 a total number of registered cases with hepatitis V virus was among 14 cases. That indicates in our country about 27% of patients with chronic hepatitis C know their status. In the last years, several measures were implemented in our country aimed to prevent hepatitis infections, early detection, and ensuring antiviral treatment. Was implemented screening testing with rapid diagnostic tests. GenExpert method is applied to confirm the diagnostic and monitor the DA treatment, and DA treatment is available, including in penitentiary system, and these drugs are purchased from the resources of state budget. Screening testing is available for general population in the health primary system, but I need to mention that the number tested percent is very low. In 2022, only 50,000 persons were tested, but need to mention also that the around 4% of patients have the positive results. Also, testing is available for key vulnerable population that is done by NGOs. Also, you can see that a small number of people have tested for HCV, but for B hepatitis, and among key vulnerable population, positive results constitutes about 14%. In our country is accessible DA treatment that was started till 2016. Above 21,000 persons received this treatment, including in penitentiary system, and of course is available for children. The DA treatment is provided in accordance with our national protocols. These protocols are developed and in accordance with the current international recommendations and guidelines. At the moment, we don't have a waiting line for the DA treatment in country. Of course, is accessible and provides prophylaxis service for key vulnerable population. This service provides according to the standard that are approved, and I want to mention that the comprehensive package of prevention service includes testing, vaccination, and treatment for viral hepatitis. On this slide, you can see the number of beneficiaries of key prevention service for key population, of course, and number of syringes and condoms distributed among this population. But I would like to mention that we didn't achieve targets for 2022, and the syringes distributed among drug users in 2022 constituent only 140. This is more very small syringes distributed per persons. Of course, in our country, we provide some public campaigns for raising public awarenesses about hepatitis, but these campaigns are not financial from budget state and not have very important our impact of these campaigns. I would like to mention that the providers prevention service and the DA treatment were subject we are nurturing and for refugees from Ukraine. This subject was discussed immediately after the start of the war in our country. In this accordance, Order of Ministry of Health was approved that it provides for the provision of support for refugees, for also provision of prevention, screening and test and treatment services. You can see the number of beneficiaries of refugees from Ukraine, number of syringe distributed visits among key population, and of course, and support and treatment, the DA treatment was provided. We supported by the Task Force for Global Health and Coalition for Health Global Hepatitis Elimination during the period 2020-21 in the Republic of Moldova, carried out the projects Hepatitis C evaluation to amplify testing and treatment, and with this way I would like to say thanks for this support. Among this project was done situation analysis in the field of viral hepatitis. Based on the things identified and challenges on this analysis was developed a action plan for combating, eliminating is more say eliminating viral hepatitis in our country, but was done very important for us exercise estimation of people infected with HBV virus and C virus, and was done modeling exercises on elimination C virus. The analysis was done with implementing specialists from national levers and territories, or collected a lot of information of data from territories on the field of surveillance, prevention services, care and access to treatment, and the laboratory capacity for diagnostic of viral hepatitis, and of course monitoring and evaluations of hepatitis. The main challenges identified following the analysis are low HCV, HBV testing, including in key population and in general population, poor implementation for laboratory screening and diagnostic service on viral hepatitis, and of course, low financial coverage for screening testing. Also, the challenging is insufficient information of general population on viral hepatitis, lack of specific training programs for NGOs and for specialists from healthcare system, lack of support for patient to retention and adherence to the DA treatment, and lack of financial resources for implementation of activities on public awareness is rising about viral hepatitis. other challenges is above surveillance. In our country, we understand we have insufficient epidemiological data. In country is a lack of national electronic register for tracking patient with hepatitis and liver cirrhosis, and of course is insufficient operational research on and epidemiological studies in testing, diagnostic, and treatment. Using on these things was developed, I said, the plan for elimination of viral hepatitis. This plan includes activities, interventions, and targets for main important areas: prevention, treatment, care, monitoring, of course, diagnostics, and strengthening on epidemiological and surveillance of viral hepatitis and ensuring data quality. Using the tool Hep C elimination with the support of Howard Medical School and Massachusetts General Hospital, of course with the Coalition for Global Hepatitis Elimination and Task Force for Global Health. We, in our country, was done elimination modeling exercises that shows we had we use the elimination scenario screening rate annually 20% and 80% treatment rate, and this elimination scenario indicate from Republic of Moldova need in the last and in the next 3 years to be screened around 500,000 people every year, and in the next 3 years we need to confirm and be done confirmation test and around 20,000. Also, in the next 3 years, every year, we need to cover with treatment and diagnostic and around 15 cases, people diagnostics. This scenario will ensure us to provide care of patients with viral hepatitis and achieve non-viremic in the country versus counterfactual scenario that doesn't achieve non-viremic situation. This scenario is also will give us possibility to decrease diseases management costs after 2030, and also we can see this scenario, if it will be implemented in Republic of Moldova, allow saved about $80,000 million to 2015. Thus, Republic of Moldova has many priorities, but one of these is ensuring the strategical plan for hepatitis elimination, strengthening viral hepatitis diagnostics capacity, and provide ensuring testing. Of course, increase quality and accessibility to healthcare system, including for DAA treatment, strengthening epidemiological and surveillance viral hepatitis, rising public awarenesses of viral hepatitis, and of course provide prevention service and treatment service for high-risk groups, injection drug users, sex workers, MSM, etc. I would like to say thanks for attention. If you have many questions, I am disposable.
Excellent presentation. Thank you so much for both of you. Questions for Sumi? You have a robust set of data. You have some of the best data on a variety of different services needed to eliminate hepatitis. But yet you feel like you need to have even better data. And I just wonder, what do you think would be improved with more data?
Yes, at the moment we haven't data on liver cirrhosis distributed by the etiological virus hepatitis. It is one of the situation because we don't have possibility to measure the impact of our activities in the country. We need to collect data on from laboratories about testing because the laboratories doesn't have a system and collect all data from all laboratories, not one from public health institutions, and private laboratories need to report this data. And we can select only data for testing provided by rapid tests because the system was the test was implemented 2 years ago, and I put these tests and Excels, and our institution reports this data. Also, I think we need to have more data about chronic cases, chronic patients, of course, and to track the patient in treatment. This is very, very important.
Thank you.
For us.
Yes, here you go.
I'm sorry, I'm Liana Gheorghe, I'm from Romania, and several questions for you. First of all, because this is a topic, I would ask how do you perform testing? Every practitioner, family practitioner, or who does this? What percent, what number annually of treatments are covered or reimbursed by the state of Moldavia? That is the first one. Then I'm very interested in vaccinal coverage in newborns in Moldavia, because I know you have a huge population infected with HBV and mostly HBV-HDV. And if you perform reflex testing, or if you, which is your policy in testing HBV-infected patients to discover cases of co-infection with Delta?
Thank you. These questions is very important. I would like to say the first questions. Testing with rapid diagnostics are available at the primary health care points, and they is done in the laboratories. Of course, is every healthcare primary point, if he have laboratory, can do this testing for populations. This is for us very important. It is accessible, the testing in rural population. That is very, very important for us. Second questions was about vaccinations. I didn't made this provide this information, but I would like to mention that vaccinations of newborns is providing within the vaccination universal program that is not part of the program of combating viral hepatitis. But the high-risk groups, including healthcare workers, high-risk groups, drug user, MSM, and other, are part of this program on this plan, and we provide vaccination. We have good coverage of vaccination about with scheme 3 doses, and in the last years we have good results with coverage of vaccination. I think it's a problem for vaccination that person that was born till 1995, because in our country vaccination, universal vaccination was started until these years, and now we need to reach that people and to apply the vaccination to them. You asked me about testing on B virus and the D virus. Of course, there is accessible testing for B virus with rapid testing, and if the person identified with the result positive, they can be tested on D virus, and of course according with the algorithm of test, and after the present this result.
Thank you. Just one follow-up question, please. You mentioned that the testing was being done by primary care providers. Is the treatment also delivered by primary care, or is there a referral system where people are referred for treatment?
At the moment, the treatment is available and provided by infectious diseases and gastroenterological diseases, but we think this is very important to decentralize it and be provided by primary health care workers.
Thank you. And maybe, one last question is about prisons. Is treatment happening for the people in prisons in Moldova?
Yes, this is accessible for this kind of people that are in penitentiary system.
Thank you very much. Thanks, Sylvie. Very much.
Thank you. Thanks.
Now let's turn to Dr. Maya Saratelli, who's the head of the Division of HIV/AIDS, Hepatitis C, and STIs at the National Center for Disease Control and Public Health in the Republic of Georgia. She graduated in Public Health and Healthcare Management at Tbilisi State University. She's led a variety of different projects, including the CDC supported HCV elimination program in the country. She's a member of the State Scientific Committee on HCV elimination, and since September of last year, she is the co-head of the WHO Collaborating Center on Viral Hepatitis Elimination in Tbilisi. Welcome.
Hi. So first of all, I also would like to thank you, Dr. Chan, for inviting me and for the opportunity to share achievements and challenges of ongoing HCV elimination program in Georgia. Thank you very much. So, yeah. So before 2015, actually, we did not have precise information about the prevalence of HCV in Georgia. So they were conducted some studies, just a few studies, but so among IDUs. So in 2015, we decided with technical support from CDC and in close collaboration with WHO, we conducted the population-based survey to identify the prevalence of HCV and so risk factors. So as you can see on the slide, so based on this survey, based on the results of this survey in 2015, Georgia was among countries with the highest prevalence of HCV. So anti-HCV prevalence was 7.7 and RNA prevalence was 5.4. According to these figures, so in 2015, we had approximately 150,000 people with chronic disease. Even in some regions, the prevalence was even 8.8 and 9%, especially in Western Georgia. Sorry. Oh. How can I just get back? I'm sorry. Red? Oh. Yeah. So in this slide, I have the main events and main achievements since 2015 to 2022. But so I will provide you with detailed information following slides. So in 2015, so the Georgian government, based on results of the conducted sero survey, so initiated the very, very ambitious program to eliminate HCV by 2020. That's with our, in collaboration with CDC, with WHO, and with pharmaceutical company Gilead. So the first step to start the elimination program was development of the strategic plan. The strategic one was developed for 5 years, for 2016 to 2020, and so with the 6 main directions: to improve public awareness, improve prevention of transmission, improve laboratory diagnostic, care and treatment, and surveillance. In 2021, so we developed the second strategy, but it's, as was decided by the Ministry of Health and the government, this was not only for HCV elimination, but for both viral hepatitis elimination. So the difference between these two strategies, in the new strategy, we have some elements of hepatitis B. As based on a decision, we started to work on HPV elimination as well. Yeah. So in 2021, we conducted to estimate the progress of the ongoing program. We conducted the second survey. And so, as you can see, results on this slide. So, in 6 years' time, the prevalence of HCV infection has decreased by 67%, from 5.4 to 1.8. I'm sorry. And so the main result is that we have an estimated number of about 50,000 people with chronic HCV infections remaining. We have very interesting results, not only on HCV, but on about HPV as well. Because as you can see, so we have very low prevalence among children. It's 0.3. That's very low to compare to adults, and this also indicates the very good successful implementation of vaccination program in Georgia. Okay, so when we started in 2015, so we have very ambitious target. So 1995, that means that so we planning to diagnose 90% of people living with HCV, and that's in absolute numbers was 135,000 people. So to treat 95% of those who diagnosed, and to get a cure rate 95. So what achievement since 2050? So for now, so we have conducted 6.5 million screenings, over 2.9 million persons tested, about 160,000 positive cases identified, and over 82,000 patients started the treatment, and with cure rate 99%. So what's our new targets according to the new strategy is to diagnose remaining 28% of people, treat remaining 36% of infected, and cure remaining 37% of those who are treated. Here you can see the care and treatment cascade from April 2015 till May 2023. So the figures I already mentioned, but so I would like just to mention about some just kind of challenges what we are facing now. So we have about 20,000 persons who are anti-HCV positive, but we cannot get them to the confirmatory test. And so we have about 15,000 people who are the RNA positive, and so we cannot enroll them in the treatment program. Now I would like just to briefly tell you about our main achievements. So as I mentioned already, since 2015, so we developed and implemented country strategic plans, as well as different clinical guidelines and laboratory steps to support viral hepatitis elimination. We conducted 2 nationwide surveys to estimate and monitor the progress of the burden of viral hepatitis infections. Since 2015, Georgia has scaled up the screening and treatment services, achieving impressive results. And so the one very important step was to establish infection prevention and control monitoring and evaluation and medical and non-medical facilities. So we started, that's one of the very important tools. So we started the program with massive PR campaigns to improve their awareness, the people's awareness about the available treatment process. So we created the integrated electronic registries that helps us to monitor screening and treatment. Very important for successful implementation of this program was decentralization of testing and treatment. When we started in 2015, we had only 4 clinics, 4 treatment provider clinics in Georgia, and that was only in Tbilisi, capital city. But now we have more than about 40 centers, including the penitentiary system, of course, and now we have even at harm reduction centers. Screening is widely accessible in multiple settings: hospitals, harm reduction centers, primary healthcare settings. So one of the very successful was innovative approach to conduct integrated screening on TB, HIV, HCV. Currently, point-of-care viremic testing initiation of HCV treatment are free of charge and widely available. All blood donations are screened for HCV and HPV using nucleic NAT testing. Very important achievement was to establish clinical and scientific committees in the frame of the HCV elimination program that help us to coordinate different operational research and different activities. Since 2019, the 90 proposals were reviewed and 75 approved, and a lot of a clinical guideline for management hepatitis C infection elaborated and regularly updated. So a lot of activities and lot of researches are conducted by the Lugar Center. We are trying through different studies funded by CDC and other our donors, so we are trying to strengthen the viral hepatitis surveillance. In 2021, WHO, in partnership with CDC, conducted an orientation meeting to introduce viral hepatitis elimination validation instrument. Georgia was one of the first countries to implement the instrument. In 2000, Georgia has reached regional targets for control of hepatitis B through immunization by WHO. So HCV elimination program has been a big driver for health system strengthening and advancing the general public health agenda in Georgia. HCV elimination program stimulates the development of other key public health programs such as Safe Blood, infection control, harm reduction, HIV and TB programs. Partnership in Georgia HCV elimination program is expanding, including the support of the organizations such as CDC, WHO, World Hepatitis Alliance, EASL, and etc. Lessons learned from the Georgia elimination program can inform programs in other countries striving to eliminate HCV as a public health threat. So I would like just to share some information about the international recognition. I'm really proud of this, that's why I like these slides very much. Yeah. So the first, Georgia was awarded the title of visionary for the European region at the World Hepatitis Summit in São Paulo, Brazil in 2017. Then in April 2019, EASL meeting in Vienna was dedicated to Georgia elimination program, and country was awarded with the status of the Center of Excellence. In 2020, we received a recognition by the CDC Director, Honor Award for Excellence in Partnering. And finally, in 2020, NCDC was National Center for Disease Control and Public Health, was designated by WHO as a WHO collaborating center for the elimination of viral hepatitis, and will serve as a demonstration platform for the European region on the topic. So as a WHO collaborating center, we will work in two main directions to assist WHO is supporting member states for developing, revising, and monitoring national hepatitis elimination action plans. And the second is mainly to assist WHO in supporting member states for improving national viral hepatitis testing strategies and strengthen diagnostic laboratory capacity. So just briefly about our, that's the program is very successful, but we still have a lot of things to do. And so just a few words about the next step. As I mentioned before, so we need to targeting interventions for linkage to care of 20,000 anti-HCV positive and 15,000 conflict not linked to care. We still need to strengthen the infection prevention and control practices in healthcare settings, which has been proven to be vital through the COVID pandemic. We need to develop legislation. Actually, we started to work on this already, to develop legislation for PWIDs to simplify their identification and treatment. as I mentioned, so we decided to expand the program to include hepatitis B elimination. So Ministry of Health has already established a viral hepatitis board, and so this board is responsible to coordinate all activities regarding viral hepatitis. And we have in this board, these board members are not only local experts, but representatives from CDC, from WHO, from different organizations. And so soon we probably will have short-term action plan for the management of hepatitis B in the country. So future activities. So we continue to strengthen viral hepatitis surveillance. For example, we established the sentinel surveillance in the country. So we need to find the laws to follow up and link to them to the program. We just finished the pilot study to implement this hepatitis C self-testing model in the country, and so we have just preliminary results. And so we are working on elimination of mother-to-child transmission of HIV, HPV, and syphilis in Georgia, and we are planning to submit to the WHO for triple elimination. So we almost finished a study to assess the burden of hepatitis B and C among dentists in Georgia. We continue to work to improve our electronic system, so through public health data modernization project, so funded by CDC, and so just some targeted actions regarding to key populations, because so as we are working to find the innovative ways how to cover, how to increase the screening and linkage to care. There's some shorter plans, and so these are already under discussions, and probably next month will be all these activities will be approved by the Minister of Health. So like to provide HB vaccination to the high-risk population, so provision of testing for harm reduction network beneficiaries, for HCV, HPV, HIV, and syphilis infections twice a year. So simplification of HCV treatment provisions in 4 harm reduction centers. Actually, we had, and so we are planning to expand this in 2 more harm reduction centers and help this key population, I mean mainly to PWIDs, to have all services in one place, starting from screening to the treatment. We are also working to integrate all these services together, so in all primary health care facilities in the whole countries. So what else? So, still we have some problems with reinfection, and so now mainly among the PWIDs, and now they will be able to get the next round of, second round of treatment for free for this population. And screening and all these services. And we are planning to pilot the initiation of HPV treatment among these groups as well. So I want to use this opportunity and so acknowledge to all our partners, as you can see on this slide. And so I would like just to say special thanks to Dr. Ward. So maybe most of you do not know that. So Dr. Ward was from the very beginning involved in the Hep C elimination program in Georgia from 2050 as a chair of technical advisory group. And so we really appreciate your invaluable contribution to successful development of this program. And plus, I want to say thank you also to use this chance and to our very close partners from CDC and from WHO. Yeah, and so we absolutely agree. So your slogan, working together, we will achieve elimination. Thank you.
Fantastic work. It's really a model program for the whole world. Any comments from anyone? One area that strikes me is that you had a goal for 2020. You made great progress, but you didn't reach that goal, so you had to set a new goal. And I hear oftentimes where people are saying, well, our country's not on track, to reach elimination, and we're going to fail before we even get started. But yet, when you look at disease elimination, the goal, the reason you have goals is to, create a sense of urgency, track progress to see how well you're doing, bring people to the table. So I'm interested to see how did you have any, how did you sort of transition, your political leadership and the whole effort toward moving toward new goals? Was it that difficult, or was it that you already had people buying into elimination, so everybody understood that you had to stay the course and keep on with new targets? Can you give us any perspectives on that, please?
Okay, so thank you. So something wrong.
I think it's better now.
Yeah,
Right,
yeah.
better.
So when I started, I said that was even from the beginning very ambitious goal. But I hope that, so as experts say, not only my opinion, we are on track to elimination. That's actually, we did a lot, and so our colleagues, so also, of course, we are very thankful to our colleagues, Georgian colleagues, because they did a lot, they contributed a lot, physicians, public health personnel, and so on, and ministry, of course. So political commitment, even you remember, Dr. Ward, that was really on a high level, right? And that's why I supported for successful development of this program. Not only that, but so that was one very important tool. Then during the pandemic, that was kind of as everywhere and everything, so everything just decreased, and screening and so on and so on. The number in treatment but so, as you ask about the new management, we have new management just 2 years ago at the Ministry of Health, and we are really happy to say that, so we see the same commitment, because the minister is very, very interested in successful development of this project. And so he always mentioned in different forum and different meetings. And so even internally, we had several meetings. Even he is very interested to support not only HCV, but HPV elimination, and provide a free treatment for infected population.
Oh, we have comments. We'll go there.
Thank you, Senan Hadanagi, CDC. Thank you, Maya, for a great presentation. I work very closely in this project, but it's always great to see this progress. But I have one question related maybe to colleagues from Ukraine and then colleagues from Moldova. I know Georgia also has quite a large population of internally displaced people from the war from 2008 with Russia, from Abkhazia and South Ossetia. So maybe few comments from your side. Were there any challenges of reaching that groups of people, and also maybe also some successes, because I know some studies have been done there. So how did you approach that, and what is the status with this population and their access to hepatitis C treatment and care? Thank you.
Okay, so there are since then, so then the problem started. So since then, the Georgian government, of course, tried to help all refugees from Ukraine. So we have, as I remember, so we have free treatment program for HIV and tuberculosis, for free immunization, vaccination, emergency care, but unfortunately, we cannot enroll them in hepatitis C treatment. So because the medicines are available only for Georgian citizens. So I don't know, so later maybe negotiations between the Gilead and our government and so what will happen, but so currently, unfortunately, it's a reality.
Thank you very much for a really nice presentation, and it's good to see update from Georgia over many years. Naveed Janua from British Columbia Center for Disease Control. I have a few questions. So first one, which regimens are currently being used in the treatment program? The second one is who pays for a confirmatory test, especially SVR assessment, as we see that in many countries, people don't come back for SVR assessment. Is that related to cost issues or there is some other reason for that?
So for all diagnostics, pays government, starting from screening to SVR tests. So it's free. But it was not free from the beginning. So it's free from 2019. Yes, all diagnostic tests, monitoring and so SVRs and so. And so you are asking about regimen. So we use now soposbuvir, velpatasvir.
So thank you. My name is Danjuma. I'm the president of the World Hepatitis Alliance. And thank you so much for being generous, acknowledging our partnerships. And I know the World Hepatitis Alliance has really done a lot collaborating with Georgia. And as an advocacy group, we've had a lot of success stories from different countries on how they got what we are looking for in terms of political will and political action. So could you share with us what were the key drivers that got the key government officials to be motivated to invest so much into the hepatitis elimination? That's number one. Then number two, I saw your presentation on provision of HPV vaccination. So I may be curious to know, do you plan to do mass general population vaccine, or do you have key populations in mind? And then interested to really see the piloting initiation of HPV treatment among high-risk population with advanced levels of liver fibrosis. That's also an area the Alliance will be very interested to know the progress of that. So most importantly, as I said, congratulations, well done. So we want to know as an advocacy group, and maybe as a lesson to everyone, how did you got the government of Georgia right from the start to commit so much into this and keeping traction, like John did ask. Ambitious goal, yes, you are still able to push, and then you move the bar, and then you're still on track towards elimination of hepatitis. Thank you.
Okay, so first of all, so just a long time ago, the question was, so why Georgia? Yeah, why Georgia? And that was decided, and so that issue was negotiated and discussed with on a very high level in Georgia. From the government, I mean, even Prime Minister was involved, and high management from CDC, from Gilead, and so, and WHO, and so. But why this? It was decided. So first of all, we had a very high prevalence of HCV. Then Georgia was a very small country. That's about 4 million population. Then we had very well, based on assessment, of course, this all these experts, that Georgia has very well established infrastructure of treatment and screening of HIV and TB. So I mean, so we had very good qualified physicians. And the political commitment was very high. And so all of them decided to show the world that elimination, HCV elimination is possible. And so when I mentioned the ambitious goal, so not the goal was ambitious, the Georgians are themselves very ambitious, and that's why they decided to be first on the road to elimination. Yeah, that's one question. Yeah, right. So, and I want, yeah, and I maybe I missed that, but it's a very important thing I want to say, that NCDC supported establishment of Cured Patients Association, and that was really very important. So when, and again, this was based on technical advisory group recommendation, and this group is still actively, so they some period, but so during pandemic, but so we are very actively involved in these activities, along, of course, with the governmental structure. And
Okay, so yeah, the HPV vaccination.
Vaccination, yeah. So free vaccination now is under discussion for key populations and medical personnel. Yeah. Only, not now for general population, but this also under discussion because the vaccination, screening and treatment. So to have a free access, but let's see. So next month we'll,
Yeah, a lot to talk about here. We can talk later. A lot to talk about. I've done a great job in Georgia. I think the other key lesson from Georgia is that with some external investment, such as with a pharmaceutical company giving some a drug donation, really spurred that national commitment and spurred national investment in the program, because the national government is certainly putting more resources into the program than they did on day one. When you say,
can you just repeat?
I'm just saying that because of the external support for the program to start it, the national government began to help build it with more resources.
Exactly. Yeah, that's why that decision was made to, it was a bit late, but so at least better late than, so, and since 2018, and actually also based on lessons learned, that if you want to achieve elimination, of course, it's better to offer free services to the population. That's why now we are discussing, when we are talking about the hepatitis B elimination, so we explaining them that it's better to provide free services from the beginning.
Very good.
Yeah.
Thank you. Thank you. Thank you again. Thanks, Maya. I'm sure we'll have more questions for you later. Let's turn to Romania. And we're going to just keep you track of the agenda. We'll hear from Romania, then we'll take a break, and then we'll hear from Poland and Lithuania after the break. But it's my pleasure to introduce Dr. Ileana Jorge, who's the head of the Department of Gastroenterology and Hepatology at the Fundini Clinical Institute, Carol Devilla University of Medicine. She's the president of the Romanian Association for Liver Disease and the scientific coordinator of all Romanian health programs on hepatitis. And she'll be joined by Dr. Cora Pop, who's the professor of internal medicine and gastroenterology at the same institution and also at the University Emergency Hospital in Bucharest. Thank you both.
Thank you very much, John. Dear chairpersons and dear colleagues, thank you very much for inviting me and giving me the opportunity to address the efforts and the country perspectives in hepatitis C elimination in Romania. First of all, I have to disclose something. I'm not a public health specialist, actually. I'm a gastroenterologist and hepatologist and transplant hepatologist. And so I see this patient at the end of their journey, and that is impressive. And that decided that had a huge impact on me, engaging me in this activity. I think I will start by setting the epidemiological background for Romania, because I don't think you know it. Actually, I start with this nationwide cross-sectional survey among adult population in Romania that has been conducted between 2006 and 2008, and it is rated. This study is rated as a high-quality input data. It was performed on more than 13,000 subjects tested in our country that times, and the seroprevalence rate in Romania was found to be 3.23 and extrapolated for all ages 3.3. with a significantly higher rate in females, in rural residents, in older than 50, in those exposed to nosocomial risk factors, and of course with significant geographical differences in our country. Using this data to forecast the HCV prevalence and the disease burden, and in estimating a year of achieving the absolute WHO goals of HCV elimination, we have this study, this modeling study performed by Polaris collaborators, Polaris Observatory collaborators. Also in our country, it was an important interaction with CDC, but not at the level of Georgia. You can see here in this modeling study that Romania, the level of 2020, has an estimated rate here of 2.3% of HCV infected individuals among the entire population. And that's mean in Romania are still living more than 400,000 individuals with hepatitis C, and Romania remains a hotspot on the European community map. Going further, the estimated year of achieving the absolute elimination targets in Romania, the current rate of diagnosing and treatment, it's far from 2030, as you can see, in the same modeling approach of the Polaris group of the CDC. How can we improve this country response? What have we done in this regard? I will show you in the beginning some preliminary efforts previously and during the COVID pandemic, because realizing as a professional group that there is a lot of things to be done in Romania, we wanted to add something to the national elimination plan as professional community. And we, first of all, we set our priorities and engage in some critical initiatives. Actually, we increase awareness in general population by structured campaigns. We met the political authorities, increasing the interest on political and public agenda of hepatitis C and viral hepatitis in general. We try to to have many intervention in media to avoid public stigma and to include for the inclusion of these patients. We tried to deliver educational programs. We succeeded actually to eliminate all the restriction in access to therapy. The only limitation, fibrosis, alcohol dependence, age, and so on. And the only limitation that we have now is for uninsured people, but we have also in this regard a legislative project in public debate and hope to eliminate it soon. Our patients, starting with 2015, received, we started with almost 6,000 persons that can be treated annually, but now this range is in between 8,000 and 15,000 treated yearly. We try to eliminate the periodic gap of 1 to 4 months between the annual therapeutic contracts during which a diagnosed patient cannot be treated. And mostly, or the most important direction in which we acted are to develop articulated screening initiatives and programs to uncover those that have been never tested, they don't know their HCV status, and to focus on underserved and hard-to-reach population. We realized that we can improve the diagnosis and access to treatment by activating screening, which is considered to be the engine behind all elimination programs. So we have to find, we must find the missing thousands of HCV-infected subjects in our population. And we developed in the beginning some pilot initiatives conducted by the Romanian Society of Gastroenterology and Hepatology, showing that this approach can work, can add a number of patients, HCV patients, to the global number that has been discovered during the national program. So we have several campaigns, the Hep C alert during the 2019 and 20. More than 50,000 subjects have been tested in medical units, and the hospital-based seroprevalence was found to be 1.39. And all these patients, most of them, have been linked to care in the same hospital unit through the gastroenterology and hepatology departments. Then we have an educate, test and treat campaign in the isolated rural communities from the northeastern part near Moldavia of our country, where the prevalence of hepatitis C is quite huge, is the highest. And we found here 2.65 HCV seropositive individuals, and they have been treated in Iași Regional Gastroenterology Center. And in southern Romania, in Oltenia region, we have several campaigns, screening campaigns on more than 15,000 subjects tested with a lower prevalence, but devoted to small industrial cities, active mining towns, or in energetic complex Oltenia, or in several car manufacturers in that part of the country. And during this comprehensive, let's say, microelimination approach, we identified two main trends. The first one was a favorable trend in the prevalence of active HCV infection with a reduction by nearly half, because, of course, also the aging and death of all the infected cohorts, but also after 6 or 7 years of using DAA. And the second trend, we still have some endemic pockets where our efforts should be concentrated, such as rural communities, socio-economically disadvantaged population, and northeastern Romania. And looking at this kind of approaches to the liver screening in population, we try to blend them. First of all, we have ACV testing, including in the basic insurance package and performed by family practitioner in all insured individuals, and they are more than 90% of our population. But a part of this primary care involvement in screening, we focus on two types of population: the vulnerable, underserved population, and screening. We have also a screening program for incarcerated people across the country that Cora will present furthermore. Okay. Let's go further. So we continued our screening efforts through this Liver South and East twin programs. Recognizes a huge problem that Romania still has with viral hepatitis. The European Commission accepted to fund Romania for a 40 months long screening program. This is Livero, a regional program for the prevention, screening, and diagnosis of chronic disease, chronic liver disease following HCV-HBV infection. It should have started in July 2020, but because of the pandemic, it was a delay, and we actually started in July 2021. On 28th of July, the Hepatitis Day, and the endpoint is expected to be at the end of November this year. Which are actually, because it is ongoing, still ongoing, the objectives to provide high quality medical services for prevention, detection, and linkage to care for previously undiagnosed HCV or HBV infected adults, being part or coming from socio-economic vulnerable groups, and the secondary endpoint to update the prevalence of viral hepatitis in vulnerable population in our country. These are the programmatic targets. Actually, together, the two twin programs should test a quarter of a million individuals from these categories. But also you can see here that the programmatic targets have been already reached and even exceeded. The target population, it is important to underline, is a rural population, especially from isolated communities, poor people with low income, below the minimal guaranteed salary in Romania, the uninsured people, the homeless, the people with no identity documents, the institutionalized in different facilities people, adults coming from orphanage or adults from monoparental families, subjects with disabilities or with special needs, the Roma communities that create a great problem in Romania, the people who inject drugs and other types of addiction, victims of domestic violence or human trafficking. And going further, I have to say that the data obtained from screening and staging in this program have been introduced into a specific registry for screening evidence in viral hepatitis, managed by the National Public Health Institute. And this electronic system has interoperability with the National Registry of Vaccination. And it seems to remain the electronic system to register all the infected subjects with the viral hepatitis, and has two levels of password protected access. The first one is the level for family practitioner. As you can see here, the name of patient, the patient is anonymized. There is a code for the patient, a code for the doctor, and the service is rendered, and the results are introduced in this database. And here on the left, on the right part of the panel, the right panel is the section for the specialty care, where you can find all the virology and staging data in each individual subject. And going further, how the process was set. First of all, we identify an NGO, a non-governmental organization with a huge experience in this area. Over the last 30 years, this Romanian association, anti-HIV, anti-AIDS, and anti-hepatitis, has been engaged in identification, in navigating, and in linkage to care of these patients. So they have this precise role in our program to identify, to ensure the access, and to navigate these patients. Then we recruited the facilitators, the general practitioners who wanted to be affiliated with our program, in between 23 and 61 per county. And as you say, there were 24 counties, a huge number. Now I think there are more than 900 general practitioner engaged in this program. The screening population has been identified, invited for a visit at the general practitioner office, where if they signed, agree, consent, they receive a risk factor questionnaire. Then they have been tested. The data have been introduced in the electronic system. The result was communicated, and the patient received, the positive patient received an appointment for the specialty care. And also for this transportation of positive patients, ARAS, Romanian Association Anti-Hepatitis and Anti-HIV, was involved. And in specialty clinics, they have been linked to care. The viral infection has been characterized, and also we perform disease staging and diagnosis. And this patient, if was the case, were included in treatment and monitoring. So this is a flow chart. It's easy. Adults residing in a selected area with previously unknown hepatitis status, 60% of them coming from vulnerable population, contacted by the affiliated family practitioner and invited for one-site visit. Here testing and risk factor questionnaire were performed. Data have been introduced in electronic system, and then ARAS appointed this subject and accompanied them in specialty care. So, and here you can see how the process goes on in the specialty care. They have been investigated. They underwent elastography, ultrasound, and routine liver function test, as well as virology for viral hepatitis. And here are the preliminary results on 6th of June this year. The project is still ongoing until November. You can see here, until now, we exceeded the targets. Instead of 240, we have almost 300 subjects already screened. You can see here the flow of screening in between 6,000 and 24,000 screened per month, with several gaps during the pandemic waves, as you can see here. And the seroprevalence overall was 1.21, as you can see here, again with significant differences between the southern part, 0.8, and the eastern part of Romania, where the seroprevalence is 1.73. And going further, both programs have already fulfilled the programmatic targets, as I said, a total number of 3,551 previously unknown HCV-positive subjects have been detected in our study with these rates of seroprevalence, but the viremic prevalence was also significantly lower than before for the southern part, 0.58, for the eastern part, 1.13, and globally 0.82 viremic prevalence now in Romania for HCV. There are some statistical significant differences between different groups. For example, females were much more affected than men. People living in rural communities, older age cohorts, people with greater number of risk factors, the partners of C or B infected individuals, those with low education, single or divorced or unemployed. So you can see here that we identify 10 counties among the 24 that have been screened, 10 counties where the prevalence is higher than the media, and these are almost all located in eastern part, and here we should enforce our efforts of screening. And I could say in this moment that the specific profile of HCV-infected individuals in Romania is the following. He or she comes from probably Eastern Romania, is a female person, older than 60, living in rural areas with 2 or 3 risk factors, with no or low educational level, and many of them unemployed. What about the results of the staging? Only 2,874 positive subjects were staged until now. You can see here the virologic evaluation. 76 of them were viremic positive, but the therapy uptake was seen only in 58% of those eligible. And as you can see, we have another problem. The disease, the HCV disease is now diagnosed in F2, F3, and F4 stages in our country. 73% of these seropositive patients have F2, F3, or F4, and almost 60 were pre-cirrhotics or cirrhotics. It's a difference between this HCV infected cohorts as compared with HBV infected ones. which are the achievements and setbacks of our program. We have some encouraging results. I can call them achievements. A drop in prevalence among young people living in urban environment with high educational levels. So the patients between 18 and 60 years of age have an anti-ACV prevalence below 0.59. Patients in urban areas below 0.61, and those with high education below, again, 0.6. But we have also several directions for action. Hepatitis C in Romania is still a nosocomial infection affecting older patients exposed during the 80s epidemic. The rate of linkage to care, it's a matter of concern, and treatment uptake also should be improved. We are thinking to support programs, teams with dedicated psychologists, ensuring and to fight with our authorities to ensure the continuity of therapy at the legislative level, avoiding these gaps during which some of these patients drop off. The therapy for uninsured people is still a problem, and the stages at which hepatitis C is diagnosed in our country continues to be a problem. F3, F4, approximately 60% of the ACV-infected population. That means they continue to require attention, medical attention, and to be retained in medical care. So my final and motivational conclusions as following: any screening is better than no screening, and there is a remarkable drop in ACV prevalence in Romania, and this is due to the combined effort of the entire community, professionals, patients organization, non-governmental organizations, civil society, media, political will that we succeeded to change. In the end, the focus now is on high-risk population. Screening for viral hepatitis should become a permanent activity as part of the standard curricular practice of every GP and specialist. We have to improve linkage to care by education, awareness initiatives, legislative changes, including permanent access to therapy. I think that the National Viral Hepatitis Eradication Plan needs to be updated with this data. And I think that blending our expertise and the political will, the elimination of viral hepatitis in Romania is not far from becoming reality because all the ingredients are here. And I hope that as soon as possible, hepatitis C will remain a simple word, not a sentence.
Fantastic. Thank you. So many lessons learned there in that overview. Thank you. Cora, did you want to make some remarks right here? After the break, yeah.
I don't know.
Okay, we can do it after the break. Yes.
The same group of initiatives addressing the issue of incarcerated people. I'm sorry. If you consider, we can join the.
Okay. Go ahead. Do you have any other comments, questions? Yeah.
Thank you. Erica Castro, GP and addiction medicine specialist based in Switzerland. I loved your talk because this is what we all want to see, how to implement strategies and models with all the people that is involved in the patient's journey, and I think it's great. It is, in fact, very, very important, this finding of very advanced fibrosis and cirrhosis in the new HCV infections you're detecting, which I can believe could be related to the fact that people are long known for, or have been long known for HCV, or perhaps not. And eventually what this means also for the future for hepatocellular carcinoma prevalence in your country, unfortunately. So my question is, as you already have GPs as a component of your model, why not decentralize also liver stiffness staging? Because we have very easy to do fibroscan and many other technologies.
Excellent point, Erika. But actually, what I want to say is that the country specificity in Romania, it's a strong bond. I can say that a strong bond between primary and specialty care. They have special dedicated groups devoted to cardiology, gastroenterology, and they cover with this group of interest all the country. And we have a very good collaboration. Actually, now we have a pilot study through family practitioner trying to identify from the primary care people with advanced liver disease, F3, F4, using Forn's index, using EPRI, irrespective of etiology. And they discover these people and link to care, send them further to the specialists, and retain in primary practice only those having F0, F1, F2, because that is a problem, having an old infected cohort. We have now most of them in advanced stages of fibrosis, prone, and we have an important percentage of them on the list of liver transplantation with or without hepatocellular carcinoma.
Thank you. Anything else? I think we can continue the conversation after the break. Thank you so much. We'll take a break for 15 minutes. There'll be 35 minutes after the hour. Lindsay, do you have it's okay. We wanted to go ahead. I think Ileana's going to have to go to a advisory committee meeting. So we wanted to go ahead and get the photos of all the speakers right at the start of the break. So everybody can come up and get a photo, and everybody else enjoy your break. And we'll be back in 15 minutes. Thank you so much. All right, well, let's get started. We had a nice long break. It's really been a wealth of information that we've received about the status of hepatitis elimination in these 3 countries. Who? We're going to introduce oh, Koa, yeah. I thought you wanted. Okay. Okay. Fair enough.
If you agree.
We have Romania Part 2. And then we'll go in the other countries. Nice to see.
I'll try to be short in order to finish the picture of hepatitis B in Romania, hepatitis C in Romania, excuse me. But first, before I start, I want to, I don't like that place. So, excuse me. I want to explain something, especially for US colleagues. When we are talking about Georgia, Moldavia, Ukraine, Moldavia, and the former U.S. countries, USSR countries, we are talking about 4 million, 5 millions. For sure, Ukraine is a special situation. Romania has almost 20 millions. It's quite different. It's not so easy to reach the goal of elimination for 20 millions with a high prevalence, with a 50 years of communism, instead of 1 million, 2 millions of prevalence of population. So I want to tell you a short story about how we have decided to closing the gap to reach the population that we couldn't till then, because when we start the population-based screening program, we've seen that the prevalence is not so high. It means that we have to check in other places, and we've decided to check on prisoners. I'll try to engage the infectious disease specialist in this kind of program. I don't know, in 2015 or 16, but they said, no, we have HIV, we are not interested in, is too difficult. So we've decided in our society, together with Professor Gheorghe, in our Romanian National Society of Gastro and Hepatology, to start first liver on European funds, and then and I thank you for this, with the participation of the AbbVie and with their enthusiasm and with our work, we've succeeded to screen in Romanian prisoners. I think that it's like this. Yeah. You know that in 2021, WHO have decided to publish an interim guidance for countries because they were not satisfied about the elimination goals, and they said, look, you have to remember that 2030 it will be soon, and you've never reached the goals. And then they decided to have 4 options. I'm sure that you are aware about. We've decided also to be in Romania option D, to eliminate B and C in the same time. And last year in 2020, EASL and CDC and also ECDC and WHO recommend again that adapt the screening program to the local situation, taking into consideration the prevalence, and start the micro elimination program. And what is that we've done? But look,
And I just said more than 10 years ago about microelimination. It was not about HCV, it was about HIV. But look, which are the targets. In order to say that a population or a group it's micro-eliminate, you have to reach 100% of people using services and 90% of tested and 70% of treatment. It was about HIV, now it's about hepatitis C. It's very difficult to reach. You have to recognize that it's very difficult to reach these goals. So we've decided together with, in the same time, in parallel with Livero, to start a microelimination screening in prisoners in Romania. We have 34 detention centers, and we had in this moment more than 30,000 person in detention, 23,000 living with a turnover of 8,000. So we had a lot of patients to screen. 34 we've decided about 27 of 34 in 3 regions. Together with the institutes and the hospitals and the university from Bucharest, which is the capital, and the most important cities, university cities from the northeast of the Romania, which with the highest prevalence, and with the lowest prevalence in the northwest of Romania in Cluj area. We designed the methodology together with the Romanian society, the methodology especially for prisoners. We organize and mobile teams with doctor residents, a lot of psychologists, a lot of volunteers from the students, and we start the campaign. First, we start the campaign, awareness campaign, a lot of awareness campaign in each prisoners in each detention center that we visited, with the educational tutorials, with videos, with flyers, with talking with doctors, with pathologists, in order to not only to raise the awareness, but to convince the prisoners to be tested. I know, I'm sure that you know that how difficult it is when you don't have an opt-out methodology. Then after the testing, we take the blood. We take the blood from the prisoners and go with in the hepatology units or gastro units from this hospital in order to stage and to start the treatment as soon as possible. Look, more than 1,000 kilometers traveled, more than 11,000 prisoners tested till this moment. But look at the last more than 10,000 not tested yet. What's happened with the data, which is one of the most important but most difficult step in the program, to collect the data and to analyze the data, because during the visits in detention center, we couldn't use any PCs or mobile or IT. Yeah, because we all the data that we collect, we had to collect on paper, and then to translate to IT data, which is the most difficult. We don't understand why, but we couldn't change this. What's happened in the hospital phase, liver disease assessment, it means that when we get we transport the prisoners from the detention centers to the hospital in order to perform the staging. will try to get a part of them one-stop shop. I will explain immediately, in order to start to finish the staging and to start the treatment. And because of administrative and administrative and legislative barriers, we couldn't recommend the treatment immediately. We find out the viremia, and we perform the staging because we could perform the staging in the detention center, but we couldn't recommend the treatment because only of administrative barriers. These are a part of data. Some particularities, not so many PWIDs, not so many like we expected. It's a special population in Romania. They live in the 19th century. In the 19th century, they couldn't use IV drugs. There are not so many. There are less than 40%, and self-reported less than 20. The most important part of them are men. Next. So the prevalence. Keep in mind the prevalence that Professor Gheorghe said. And compare with this data. The prevalence only in this data that we could analyze since now, it's more than 7, and in some parts it is more than 9. It's more than 9. The prevalence, it's 10 times. It's almost 10 times more than general population. It means that we have to continue and to return in this group, in these vulnerable groups. This is the real situation. We couldn't assess and treat just 42% and treat just 32, even if we made a lot of efforts in order to dynamize the process, in order to shorten the process, only because of administrative barriers, which were the limitation, difficulty of awareness campaign. There were the first campaign in Romania, and maybe we're not so talented, but we'll try a lot. And also the need for transport prisoners, it's also very difficult. Instead of one-stop shop, instead of opt-out recommendation like in USA, like in Australia, but which are the opportunities especially experience for future project that we are involved or we've been involved. Plans for the near future, two kind of plans: to continue testing in detention center and to return to improve our model to one-stop shop, and if it is possible to propose a model of best practice, maybe with opt-out, which I think that it could be the best, but I don't know if only in, I think just only in UK, in Europe it is possible with opt-out. I don't know if we'll succeed or not, but one-stop shop, it will be better than now. And also to integrate this model in national control plan in order to identify some new funds. And the second, regarding the Ukraine, regarding our neighbors, there are only, I have to explain, from Romania have been passed more than 3.5 million of Ukrainians, but they just 100,000 live in Romania now. More than a part of them are employees, and they are, since the beginning of the war, they are fully insured. fully insured, they can reach all the treatment for diabetes, for HIV, for hepatitis, diagnosis and screening for all Ukraine's refugee. Even if he is not working or even he is working, there are a lot of young women with children. There are not so many. There are not so many men. But we have more than 200,000 employees from out of Europe. India, Pakistan, and other countries from Asia especially. We'll have to focus on them because there is no one to be interested in. The refugees and the authorities, the local authorities or the national authorities are not interested in screening for hepatitis at the beginning of working, because they have a lot of employees contract, or at the entrance in the country. So we'll have to design a screening model especially for these foreign workers. So thank you.
Thank you very much. And we'll, that's fantastic description of the program for prisoners. We want to make sure we get everybody on the program up in front of us. So let's move on to Professor Christoph Tomaszewicz, who's the head of the Department in Clinic of Infectious Diseases and Hepatology at the Medical University of Lublin in Poland. He's holds a variety of different positions, including being head of the expert committee for both hepatitis C and hepatitis B, and works with EASL and a variety of other international organizations. And it's great to have you here. Thank you.
Thank you so much for the invitation. So looking back at the presentation, which were prior to mine, I have to say that we are in a completely different situation, because first we start with a very low prevalence of Hep C. If I compare to Georgia, for example, then you have 7 or 6% population, we have 0.4 viremic patients. So when I'm looking at the target for WHO, target for elimination, the main target is the reduction. So when we start from the top, it's easier to reduce than when we start in the bottom. So that's first. The second, it will be not a story of success, because I want to show you that we have a lot of problems with the elimination, with achieving these targets. So I try to be very concise with my presentation, but I just want to show you what problems we have with this elimination. So first, that update, it's 2018, so it's not an update, but you know, when we want to eliminate, we have to know what kind of patient we may expect for this identification, because the main problem in Poland is identification of patients. We don't have too many patients who had been infected because of drug using or something like that. So we still have a dominance of medical devices or medical procedures related to infections, but it's less than it was, let's say, 10 years ago. The second, we still do not have the national plan for the virus elimination. So unfortunately, I'm showing you the numbers. This is more than 700 screening patients, screening people, but all this screening program was supported by industry. So we did it with the help, in this case, with the help of AbbVie. And now we have some more programs. We also are supported by other pharmaceutical companies. For example, now we have a program of the screening in psychiatric hospitals, psychiatric patients, because we expected the high prevalence. It's not as high as we expected, but we are not supported by the government. When you look at the when you look at the percentage, you know, the diagnostic laboratory, we have an idea that the AbbVie had an idea to open screening procedures for everyone who is interested in screening. Just he has to go to the lab and say that he wants to be screened for Hep C, and they offer both anti-HCV and HCV RNA screening for these patients. But when we look at the other points of testing, for example, in the hospitals, it's 0.7. So we have some recommendations for screening that anti-HCV screening in Poland should be universal screening. So everyone should be screened for Hep C. However, if it's not possible, we have to focus on hospitals, on some private medical centers, in diagnostic labs, etc. And what is really important, we have to use rapid anti-HCV kits. Otherwise, we will be not able to screen those patients. Of course, we have an influence on COVID-19 pandemic. So if you look at the numbers in 2021 and 2020, it was much lower than before. 2022, we started to go up with the number of tests which were used. But if you compare these curves from 2020 and 2019, is a huge difference. However, this graph is very important because we can see that we have two peaks. The first one, which is very obvious for us because it's related to medical procedures. So all the patients who had been infected many years ago. However, there is also a peak in patients in the population between 35 and 40, which probably they could be also infected during medical procedures. However, it's a chance they could also use drugs, etc. So we have two populations which should be screened very carefully. Of course, if you go further with the tests, if you go more tests for patients, we have a bigger chances to find these patients. But these are the results of the testing in patients who had ALT more than 35, which for more tests is still a normal value. However, is upper limit of normal. So in these patients, you see we have 3% of the prevalence. If you compare with 0.4, it's quite important. I'm showing this graph because we have a program for 40 years old plus patients. They are tested for ALT and AST and some other biochemical and morphology. So for me it's a success because we have a lot of patients from this project, from this screening project for let's say this is the health checkup for these patients, and if they are found to have ALT more than 35, they are tested for Hep C. Unfortunately, when we look at the progress to WHO target, we still are not on track. So if you compare this map, the Europe map from 2019 and 2020, some countries succeeded and they changed their status. For Poland, we still are not on track. Why is that? Because we have no chances to achieve this target before 2030. So as you see here, for 90% diagnosed, for 80% treated, for 65% reduction in mortality and 80% reduction in incidence, we are about 2050 or even 2060. What happened? What is our success? We had struggled with the government to offer or to support all family doctors with free testing for anti-Hep C for all patients. And in June 2022, so 1 year ago, we were very happy because they approved the free testing for all family doctors. So they had a chance since July the 1st, 2022, to offer testing for everyone. However, if we calculated the number of tests which was done during this is not the project. This is a law. They could test the patients. They are paid with extra money for this testing. But you see, during first five months, they tested 15,000 patients, just 15,000 patients, which means they will test about 37,000 patients per year. This is nothing, because we tested, so they maybe 40, 50,000 per year, because we tested in this pharma sponsored campaign more than 225,000 patients. And what is necessary for WHO target, we have to test 3 million people per year. So using these family doctors with this trend, we will not succeed. We will not achieve any success. What about people using drug? So this is a Swiss contribution project. Sorry for these Polish letters, but I have no chance to change it. But this is just to show you that the prevalence is more about 50% about these drug using patients, and for those who are injecting drugs, it's about 64%. So we have a huge population of drug users who are infected with Hep C, and they are not tested. This is another shame for us, because here we have Polish prisoners. This blue bar is a number of prisoners, and the brown bar is number of tests done for Hep C. And you see how many tests we do for these prisoners. We have also the law, which is they should be tested, but no one is interested in testing prisoners. I don't know why, because we offer them that we will diagnose these patients, we will do everything. We accepted non-invasive tests, not fibroscan, anything. APRI, FIB4, etc. is enough for us, for our program, but they are still not tested. This is just a few percent of prisoners who are tested for Hep C, and the prevalence, as you can see, is about 7–10% of those prisoners. So, and about half of them, they are identified for the first time. So they have no idea they are infected with Hep C. This is our recommendation from our Polish group of experts, which it was released at the end of 2022. So we focus on where these patients should be tested. They should be tested in primary health care settings, in hospital emergency departments. This is very important, because so far in Poland, this is not obligatory testing patients in these emergency departments, and prisons, which is necessary to introduce for the testing system. So far, we have no national strategy, unfortunately. It is said that it is on preparation. It means that we gave the government the ready national strategy, and this is not accepted by government. So what I'm jealous about the previous presentations, you have political will. We don't. We have no political will. They are not interested in the elimination of Hep C, because they do not consider Hep C as a problem, as a health problem. Maybe because this is just 140,000 patients, not 4 or 5–6 million. We have no reliable national epidemiologic data. What we have is unlimited access to free DAA. So we can give everyone treatment. This is not a problem. This is free of charge. Everyone can be treated. And I have to admit that 2015, we were probably the first country with the open access to everyone who is infected with Hep C. 2019, but nothing changed. So a few words about refugees, because as you know, Poland is probably we have the highest number of refugees from Ukraine because of war. This is just a few numbers. We consider that it will be about a few millions from refugees from Ukraine. We have no time to go in details. The main population in these refugees, they are females aged 1865. When we look, this is data from the August 2022, but it hasn't changed too much. They are very interested in working in Poland, which is good for us because they have insurance and they feel much better working in Poland. And for the question, do you intend to return to Ukraine? Just 9% said no. So they probably will be very eager to go to Ukraine back. They have an access to healthcare, and they know they have an healthcare in Poland. But when we ask them about barriers, so the information barrier is the main barrier for these refugees, and the most used government health facility and private health facility. So so far in 2022, in our program of treatment of Hep C, we treated 5,825 patients and just 57 patients from Ukraine. They have unrestricted access to medication, the same like in Romania. They have not to be insured, but the problem is that a lot of Ukrainians, they received Polish ID number, and they are not considered as Ukrainian for the project. So probably we treated much more patients from Ukraine, but there are still a lot of should be done. And for the future is means July 2023. We have a patients organization which is Star of Hope. They are really engaged in the process of screening, of treatment, to achieve this population, and they have some plans for this approaching month. So they want to give the stories of patients treated in Poland. They want to share the video. They involve bloggers from Ukraine. So they use these resources for having better access for Ukrainian refugees. So probably I expect during next months we will have much more patients from Ukraine. What is necessary to know that we don't use Polish media because Ukrainians do not watch Polish TV, and we don't want to arouse negative mood and stigmatization. I know we are in 21st century, but we still have to talk about stigmatization in Hep C, unfortunately, but this is the truth. Thank you so much.
Questions? Thank you. Oh, sorry.
Hi there. Thank you very much for your presentation. Marcelo Naveira from WHO Europe. A question regarding the political will. Do you see that there is an opening and opportunity to maybe engage hepatitis in a national cancer strategy? I know that the cancer strategy mentions somehow hepatitis C, hepatitis B, but perhaps that will be the way to go with NCDs. A lot of colleagues from University of Antwerp, Achieve, or Hepatitis Alliance, the CDA Foundation kept growing this message that perhaps hepatitis is losing the steam, and we need to engage somehow in the cancer train and collect some momentum for all the member states.
We thought about that. So we have a project for anti-cancer prophylaxis, and we wanted to Hep C and Hep B be introduced in this project. But the government gave family doctors the tool, the access to free screening. So the problem is that family doctors, they are not interested in testing a lot of patients. So for the government, they click, they are okay because they gave the tool. But for us, the family doctors, they don't test patients.
Would be interesting to hear from Romania and some other situations, how they got their family physicians interested in testing. Maybe that would be helpful. Do you, anything come to mind in that regard? Or Moka, do you want to talk?
Well, thank you. Mojca Matičić from Slovenia. Thank you for this presentation, and I was really surprised. I thought that Poland is doing much better according to some other data that we got, but I'm so sorry about it. Have you tried with the micro-elimination in the groups that are already, that they do have their medical records, like, I don't know, HIV positives or some others? Because to start with that, this is the easiest way, I think, and then to engage others to go wider.
Thank you for this question. That's why I shown the routes of transmission in Poland. So for HIV patients, this is not a problem. All HIV patients are tested for Hep C, and maybe they are not eliminated with Hep C, but I have a feeling that we treat all patients with HIV positive. This is not a problem. We wanted to do microelimination in prisons. That's why I showed that we also convinced some people responsible for prisons that they should be tested. But there is a gap between those who decide about having some projects and those who have to do these projects. That's the main problem. And other microeliminations, what can I say? We have a project for the microelimination hemophilics, but this is probably not a problem anymore for the elimination, because they are tested for Hep C. So
It's here. You're right, it's here.
Thank you. That was an excellent presentation. Thank you so much. We learned so much about Poland. Appreciate it. Now let's have Lithuania come forward. Dr. Limas Kupčinkas, who's the chairman of the Lithuanian HCV Screening and Elimination Group. He's the chairman of the Division of Biological, Medical, and Geosciences of the Lithuanian Academy of Science and head of the Hepatology Unit, Department of Gastroenterology at Lewis Hospital in Lithuania. Thank you. I know you have to leave early. Thank you. Excellent. Thank you for coming.
Dear colleagues, I would like to share with experience of 1 year hepatitis C screening program in Lithuania. The program started last year in May, and planning the screening we based on our pilot study in Port City, Klaipėda, where was tested in primary healthcare center by general practitioners, about 5,000 consecutive patients by serological tests, and we reveal prevalence 1.7. It is average prevalence, and in hepatitis C seropositive patients, we reveal that most of them were infected by way of unsafe medical procedures, mainly related with blood transfusions or being blood donors before 1993, and only near 30% of patients were infected by use of intravenous drugs. And these findings in planning of our hepatitis C program revealed some differences in Lithuania in comparison to Western Europe countries. In most West Europe countries, seroprevalence of hepatitis C is low, and the highest risk is in so-called marginal group. In opposite of that, in Lithuania, the seroprevalence is moderate, and the main route of transmissions were through blood donation, the blood transfusion, and also other non-medical, unsafe non-medical procedures like tattoo and the intravenous drug users was the significantly smaller group of possible way of transmission. So our initiation group of gastroenterologists and infectologists defined the two main target groups for which the hepatitis C serological test could be done by general practitioners. The biggest group is patients born between 1945 and 1994, before when hepatitis C testing in Lithuania was introduced. Also, the positive patient families members, and for them is foreseen once per life serological testing by general practitioners. And the second smaller group, it is marginal group, intravenous drug users, persons who were treated in addiction centers, and HIV patients for which serological testing is foreseen to do annually. And starting from the May of last year, about 8,100 of people was tested. It is about 1/2 of population foreseen for testing. And you can see that general practitioners tested very actively. At the beginning, the number of testing was lower, but after 5 months, it became as plateau, reaching the near 100 tested persons per month. So during first year, we tested, I tell, about 800,000 of people born before 1994, and also near 7,000 people of risk group. And really we tested of half of population foreseen for testing. Seroprevalence in a risk group was 31%, and in total population is about 1.5%. And patients seropositive patients are referred to gastroenterologists and infectologists. So the number of treated was about 40% of possible HCV RNA positive, but this delay was related with the sending procedures and some problem with drug supplying to Lithuania, because number of treated patients during the the last year increased 2.5 times in comparison to previous year, and it was not planned that so much patients needed treatment, and some treatment delay patients. Some patients are in waiting line for 3-4 months. And finally, what possible scenarios for achieving of World Health Organization targets for hepatitis C elimination in Lithuania? So we implement screening, treating treatment and screen and treat strategy, but of course we need also more work on prevention, especially on this marginal group, the patients in prison, because they could be the reservoir for new cases. And in case that during first 2 years we can test about 90% of targeted population, it was calculated prognosis that we could prevent 120 new cases of liver cancers, 90 cases of decompensated cirrhosis and possible liver transplantation, and 150 deaths from hepatitis C. So finally, we could conclude that the motivation of general practitioners to test and refer seropositive patients to gastroenterologists or infectologists for treatment is very high. It is necessary to solve some problems with treatment delay, but of course prevention or effort should be directed to target population, especially prisoners and also intravenous drug users. So, thank you.
That's an amazing program. It's one of the most remarkable programs I'm aware of in Hep C elimination. Just getting that planning and getting that national commitment to make that financial investment to promote testing at the family practice primary care level is truly amazing. Was it just your charisma and leadership that made it possible, or what was it? A personal story, professional expertise, modeling to show the impact? What do you think was helpful to get the national government to make that commitment? Microphone, please.
Yes. If I could say that my experience why in Lithuania such hepatitis C elimination efforts are quite successful, it depends on several factors. First of all, really, we do not have any elimination or screening program in Lithuania because the program usually require a lot of administrational efforts, different meetings, training, education, which require additional money. And in Lithuania, for healthcare promotion programs is special requirements, and it's require money. But we agree with our health authorities that we do very simple thing to introduce promotional service for general practitioners for HCV testing. It's of course, first of all, we plan that it will gradual testing for 10 years and with quite small expenses, but really during first year was tested half of really targeted population, and the health authorities agree that maybe now they have some resources for 2 years to do that, and further testing would be unnecessary, only expenses for treatment. And other, I could see, key factor of success that we involve in our negotiation with health authorities, the Lithuanian Europarlamentars who knows about this program from some events in European Parliament, and we do the video conference because that time was COVID with health authorities people from Ministry for Sick Fund and also Europarlamentars. And it is also was quite important some pressure from European institutions. But of course, for our sick fund, it was very impressive the simplicity of the program. Only simple promotional fee, no any other additional expenses, even if was necessary, unnecessary, very big advertisement program. So it was quite, I could tell about our, how to say, way to this potentially success.
Yeah, no, you're on your way. It's successful in many ways already, and you're on your way to achievement of elimination. It's really, really remarkable. So thank you so much for sharing that with us, and we'll keep in touch. So we're going to have we have some time for some discussion. I think we're already having some general discussion, but George, I didn't know if you had any remarks at this point to kick us off in the discussion, or.
I can see that it's always very nice to see the efforts of the countries that have been doing for especially marginalized population. And I perceive this situation as extremely optimistic, in an optimistic view, because when we started drafting the elimination targets for 2030, one of the obstacles that we had in Europe, but also in other countries, is what are we going to do, what governments will do eventually with marginalized population. And back then, the conversation about, prisoners and conversation about, people who use drugs, it was very intense. And we had the guidelines. We had a need for the scientific community to intervene and say specifically in the guidelines that people who use drugs are a priority in order to achieve elimination. This was a signal for governments. So now it's very nice to hear that, all these countries around the globe are doing such a fantastic work. And of course, the good news are over. We need to struggle a lot more in order to achieve our goals, and we need to focus. And the other remarks that I have is that, as we see through the example of Georgia is a very important example, which had all the funds that one can ask. And even though they couldn't achieve the targets that they had, which means that, it's not a matter of money. It's a matter of, public health, political will, and changing the way that we are doing stuff in a completely new way, one-stop centers, etc., etc., etc. So I think all this discussion and all these examples from around these countries are extremely valuable. And I think all the lessons that we take, we could, think of them and continue our efforts.
Yeah, I think bringing this all together, as I mentioned earlier, I think we can really, help put together a toolbox of some of these strategies that we're hearing about this afternoon. Marcello, I didn't know if you had any other thoughts from your, no. Okay. Yeah, Tangelo?
Thank you, John. I would like to sincerely appreciate you for the beautiful presentation. And I think this is probably what we at the World Hepatitis Alliance had always advocated for, to strike the connection between the community and clinicians, and then to see how we could get clinicians to become advocates so that we all together co-create this, attain this goal of elimination of hepatitis. So I think it's a good practice to see that the GPs and other clinicians are involved in the screening and linkage to care. However, the only concern I would have is with the goal of WHO to see simplification of services. Will that not be a challenge where people have to still be referred to the specialist or the hepatologist, right? That is the only concern I have, but I think it's important to really bring clinicians to the table. Then also, John, the global community set targets for 2030. And I remember even the SDG goals, certain LMIC countries started complaining that they cannot achieve those goals, very ambitious goals. So it is good to set ambitious goals. And like I think Georgia, they kept measuring and then evaluating what they're doing and motivating themselves to do more. So yes, it's beautiful. We have the goals and 2030 is just by the corner. 2025 is a midterm evaluation of these goals. So we need, as Alliance, and I'm happy, John, we've always had these good collaborations and country programs. We all need to speak with a collective voice to get this political action beyond political will. We need to move the needle. How many countries are on track to achieve elimination of hepatitis by the 2025 midterm evaluation? Very few, maybe not 3 or 4. In LMICs, probably only Egypt, if it is even LMIC. So collective action, collective voice, bringing everybody together, clinicians, policy, patient groups, probably we might begin to hopefully talk about elimination. But I just hope that we get to achieve elimination of hepatitis, hopefully. Thank you.
I fully agree with that, except to emphasize, instead of just really heavily focused on we're not on track to reach a goal, hopefully you can see some examples today of we are on track in many ways of putting in place the services needed to achieve elimination and just really sort of stick to what's immediately in front of us rather than all this projection of what's not going to happen by a certain date. I think it was demonstrated here, at least for me, that there's a lot of good work going on in these countries. There's some real role model strategies going on, and we need to promote those and share those so that others can take advantage of that and really show that this is fully a feasible exercise that's going on. And you got incredible program in Lithuania that, they're keeping it simple, but they've really sort of hit the magic target of what really motivates testing. As you pointed out, that all important linkage to treatment really has to be strong as well. And so how did that happen? That came up in the Romania too, there's still a pretty sizable percentage of people not yet treated, even though they've been diagnosed. So we have to look at that. But what we learned from, Ukraine, they continue to develop and support their program amidst, high stress from being attacked by another country. So we really want to thank you for your work and let us know that we're supporting you in your efforts for hepatitis and just in general for a successful outcome to what you're experiencing. Moldova, a very small country, but really well-developed program. You have an immense set of information that you put together, even though you think you need more. You really gave us some great examples of tracking progress in testing and doing a lot with treatment. And so it's really was great to see, and it's great to have been part of your work. So thank you very much. And then, as we mentioned for Georgia, for Maya, really shows how a program continues to evolve and how you have to change your strategies as you move along. Moving from a very focused, centers of treatment to more broad-based, simplification of care throughout health systems. Moving to improve prevention, such as moving to virologic testing for blood donations. That's not done in very many countries, even now. So it's just really that continued focus on quality improvement to reach that goal. And then once you show that you're successful, even though you may not hit that initial target year, you've got that buy-in to your program for people to move on with you to that new target year. And I think that's what was evident for me. And then for Romania, the country and the European Union with the largest burden of hepatitis C, just the amazing program they're putting together to engage more, promote more testing, get treatment paid for, have a data system in place to track progress. and really showing how the importance of hepatologists and specialists to step out and really become a community and public health focused and have a public health approach to move beyond specialty care, to recognize how you really have to disseminate that. And we have an opportunity to do that because of the simplicity of hepatitis C treatment. And then the challenges for Poland, a low burden country, but they're well aware of what needs to be done in Poland. And maybe we can have some follow-up to see how we can help you have some strategies to better engage your primary care practice and get more national engagement for you. And look forward to helping you develop a profile for Poland as a step toward that goal. And then Lithuania, as I've already mentioned, is just an amazing program. And so I feel very energized about the whole afternoon, and really feel very fortunate to be part of a global disease elimination program that's going to be successful. And I want to thank you all for being local champions for hepatitis C elimination, because that's what really makes it all come together. So I want to just thank you so much for your doing the work and being the strong voice in your countries and strong delivery of services that's making these achievements possible. We still have a ways to go, but progress is being made because of the work you're doing. So I want to thank you very much for that as representing the coalition. You have any final thing? Anything else? Any other comments? Anyone? Okay.
Thank you. I don't want, this is not the last word, but I was really, I'd like to congratulate Lithuania really from my side as well. And there was a sentence that touched me a lot. Make it simple. Really, this is the main word that I think has such a power. Because in my country, Slovenia, this is a 2 million population, and we started very simple more than 20 years ago. This was a self-founded interdisciplinary group of experts. In 1997, we did a very simple strategy on 3 pages, no paperwork, administrative work, meetings, time and money consuming, as you said, and we just started to do it, you know, and now we have the lowest prevalence, like it's 0.07%, so we are nearly there, you know, but simplicity, and congratulate you on that. Of course, you need a political and country support, that's for sure, but anyway, make it simple, I think that's the word.
So, sorry, John, just a last word from us, and it's just an appeal to everyone to please work with community groups, identify strong patient groups. The people-centered care needs community involvement, and I think I'm happy when I saw Georgia and other countries really working with community groups. So in all the countries, we have like Alliance, we have members all over, so it's very important to involve community groups in all the activities that are going on. Thank you.
Yes.
We only wanted to thank you for the invitation, to thank all the partners. I think we can be partners in the future. We also thank for the support for Ukraine, as Ukraine, as you know, in our problems. And we also solve the problems and obstacles in other countries, and we see the points of the growing for us. So I think it was very interesting, and it was pleasure for us to be a part of this family. I hope we will be family in the future. Thank you.
We are a family, that's for sure. I just wanted to end, we put together, if there's no other comments, just put together a call to action up front after, talking to the presenters and seeing their presentations. Just hopefully you can, agree with this. I think our takeaways were, some calls to action, focus on marginalized populations, to scale up the services for equity, scale up community and clinic-based testing, to screen and diagnose hepatitis C before they develop severe liver disease, as we were seeing in Romania, for example, expand access to hepatitis C treatment through simplicity, as we were just remarking on service delivery, and that can take many forms, and Lithuania provided one example of that. Strengthen information systems, we heard that from multiple countries, the value of data and the importance of getting the information systems to understand where you are in your progress toward elimination. Increase collaborations across clinical specialties. We focused a lot on primary care today, but there are others to really get this to be an all health system approach. Infection control continues to go up. It was a problem for Lithuania, came up in Romania. So we don't want to, we always want to remember that the most common mode of transmission of HCV continues to be in healthcare settings. And we have to continue to improve infection control. And we've talked very much about strengthening national commitment in the country, such as Poland, and to see and whether they need help with a budget-based planning, to see the value, improve strategic planning, the involvement of community-based organizations to make this a civil society priority, just the importance of national commitment. And then through all of that will be helped by raising awareness through all these different stakeholders. So does everybody agree with that? So thank you very much. Please sign on if you agree with it. A copy of that QR code. Please keep in touch with us. My email is jward@taskforce.org. Please, please come to our website, sign up for our newsletter. We put out a weekly news summary for hepatitis elimination. Look forward to working with all of you to advance progress toward hepatitis C elimination. Thanks again. Take care. You want to sign? We have to sign that sheet for the call to action. We already have a few signatures, so if you would like to come up and show your support. We want to do a group, everybody should come up forward. We do a group photo.